So, hi everyone. It's really great to be here this evening. Thanks to Carmel and the team for inviting me along. Before I begin, I'd also like to acknowledge the traditional owners of the land on which I'm calling in from today, the Boonwurrung people of the Kulin Nation, and I pay my respects to their elders past and present. It's also really nice to see a lot of familiar names and faces in the audience today. So just a little bit about the Multicultural Centre for Women's Health. We're a national community-based organisation run by and for migrant and refugee women. So I'm here to talk about our recently released Sexual and Reproductive Health data report and a little bit about a health education program that we're leading, which responds to COVID-19, called the Workforce for Multilingual Health Educators, or the Women Project. So MCWH's purpose is to advance health equity, and we advocate for greater understanding of migrant and refugee women's health. We also advocate for positive social, cultural, and political change to the health system. And we do this work through our bilingual health education program that we've been running since 1978, when educators used to visit migrant women in factories around Melbourne to share health information about contraception in their own language. So today we have a team of highly skilled and trained health educators speaking over 30 languages in total, who deliver tailored, responsive and accessible health information for migrant and refugee women on a range of topics, including sexual and reproductive health.
Hi Maria, we're seeing your notes page, not your slides. Sorry.
Okay. Let me just see how I can remedy that situation.
Yeah, all good.
Is that better?
It was, and now we are back to the image.
Yeah, okay.
Yeah, better.
Okay, I'm just going to have to wing it and I won't use my notes. So bear with me. So a little bit about the approach that MCWH uses. We use a feminist intersectional approach to understanding migrant and refugee women's sexual and reproductive health. And so what does this actually mean in policy, research and practice? It means that it's not a stand-in for diversity, and it means that we look at how power operates within the context of migrant and refugee women's lives. So the questions that we might ask include, how do the conditions in which women are born, grow up, live, work and age contribute to poor sexual and reproductive health outcomes? And how does racial and gender inequality intersect with those conditions? We might also ask how our political systems itself, so our health, our migration and our economic systems contribute to health inequality, and more importantly, what is required for transformation. So we've recently released our data report and our Act Now advocacy paper, which collates the most recent and up-to-date research across key areas of migrant and refugee women's sexual and reproductive health. And the Act Now paper draws on the research and over 40 years of working with migrant and refugee women and offers recommendations for change. So our first data report was released in 2010 and then again updated in 2016. And now in 2021, unfortunately, the data tells us that not much has changed when it comes to migrant and refugee women's sexual and reproductive health. There's not a lot of data on migrant and refugee women's health, and there are a lot of gaps as well. But the evidence that we do have suggests that migrant and refugee women are at greater risk of suffering poor maternal and child health outcomes, including higher rates of perinatal mental health issues, are at greater risk of contracting some sexually transmitted conditions such as hepatitis B, may experience prolonged and severe family violence, are more likely to experience barriers to accessing support, are less likely to have evidence-based, in-language and culturally appropriate information about contraception, and are more likely to experience barriers to sexual and reproductive healthcare, including abortion care and support services. So I won't go through all of these statistics because they are in the report, but I guess to note this statistic here is that migrant and refugee communities often have lower access to contraceptive methods and lower use of contraceptive methods. So that's 60% of people born in non-English speaking countries use contraception compared to 77% of people born in mainly English speaking countries. The statistic around hepatitis B is also really important to note as well. So approximately 70% of people living with chronic hepatitis B were born overseas. And while the prevalence of chronic hepatitis B infection among people born in Australia is 1%, it's much higher in certain cultural communities. So 6.7% among people born in Northeast Asia and 5.1% among people born in Southeast Asia. Again, I won't go through all of these statistics. They're all in the report, but it's really important to note that migrant and refugee women tend to access antenatal care later. And we know that timely access to antenatal care is really important for the health of the mother and baby and leads to lower interventions and poor maternal and child health outcomes. So 70% of mothers born in non-English speaking countries attend antenatal care in the first trimester, compared with 76% of those born in Australia. When it comes to pregnancy outcomes, migrant and refugee women also experience higher rates of certain conditions, for example, preeclampsia and eclampsia. Gestational diabetes is also higher among certain cultural communities. We can see here people born in Southeast Asia were 1.7% times as likely to be diagnosed with gestational diabetes compared with people born in Australia. Migrant and refugee women were also more likely to have interventions when it comes to birth, so more likely to have instrumental vaginal birth or caesarean section compared with Australian-born mothers. Sadly, there are higher stillbirth rates among migrant and refugee groups in Australia as well. In 2018, the rate of stillbirth was 6.7 deaths per 1,000 births for mothers born in Australia and 7.3 deaths per 1,000 births for mothers born overseas. And we can see here also that for certain communities, the rates are even higher. So in our report, we went through a lot of data that looked at sort of barriers and facilitators to access for migrant refugee women in terms of sexual and reproductive health services. And systematic reviews found that a lot of the barriers that migrant and refugee women were experiencing were not based on, cultural practice or cultural ways of being, but could be seen to be systemic barriers. So as we can see here, the cost of services, discrimination, lower levels of health literacy, a lack of culturally appropriate information, and that's spoken and written, transport difficulties and lack of infrastructure, and lack of culturally responsive service delivery. And the facilitators, I mean, if we see that these are the barriers, it's kind of would be easy to see what some of the facilitators might be. And that's the provision of interpreters and bilingual health professionals, provision of health professionals who are women, multilingual resources, flexibility and accessible services, including outreach and home visits, patient-centered care and culturally responsive care, and of course, continuity of care, which is really important in terms of building trust. So as I mentioned earlier, the Multicultural Centre for Women's Health has been leading a really exciting and important project called the Women Project. And that project places migrant women, bilingual health educators in all of the regional women's health services across Victoria to deliver health information about COVID-19, but also about mental health, sexual and reproductive health, and a range of other health topics. So through this project, which has only been funded for 6 months, our educators have been able to deliver 96 health education sessions run in 22 languages, and we've reached over 1,800 migrant and refugee women. And there's this quote here by one of our educators, Shweta, that I just love because I think it really demonstrates, you know, the impact of this program. And that's, she says, through this project, we laugh, we share our stories, and we support each other. By offering health education to women in a culturally appropriate context, we break down barriers of accessibility and communication, empowering them to take a bit more control over their life and their bodies. And I'm really happy to see some of the educators in this meeting today. So I'm sure if anybody has any questions about the Women Project, they'd be more than happy to chat about that. So just sort of finishing off, I wanted to talk about moving forward and some of the things that we can do as practitioners, as researchers, as policymakers, as activists and advocates to really improve or advance migrant and refugee women's sexual and reproductive health. And the first is to apply an intersectional lens to all of the things that we do. That's our research, our policies, our programs, and our projects. And this ensures that those who are most in need of access to services are being reached. And following from that, we need to ensure that our projects targets those migrant and refugee women, especially those most marginalised. And we know that migrant and refugee women are not a homogenous group. So we need to think about how our programs will reach those most in need. So that might mean allocating additional funding for bilingual health outreach workers who understand the issues for migrant and refugee women and understand the contexts in which migrant and refugee women access and experience sexual and reproductive health. The third one is form equitable partnerships and prioritise migrant women's leadership. Collaborate with migrant women's orgs for expert advice to develop policies and responses that are culturally appropriate, culturally responsive, and thinking about all barriers to access. And that includes structural barriers to access. So what does it mean for an international student who's on a particular visa and they can't access services? How can our advocacy meet the needs of those women? We need data, we need a lot of data, and we need data that is disaggregated by country of birth, cultural background, and visa status. And we really need this data to understand the gaps in service delivery so that we are reaching those most in need. And finally, support a statewide infrastructure that delivers community-led, in-language and culturally appropriate education. And so, for example, the Women Project that I was just talking about is only funded for 6 months. And while we can all agree that, you know, the impact of that program is enormous for migrant and refugee women, we really need to ensure that the funding is sustainable and it's targeted and it's ongoing. And just one last slide from me, because it is International Safe Abortion Day. I wanted to flag that MCWH, along with 1-800-MY-OPTIONS and support from Women's Health Grampians, have produced some short videos about abortion. So the videos cover your legal right to abortion in Victoria, the types of abortion available, how to get an abortion, and who to contact. And the videos can be accessed from our website, and they're in Burmese, English, Farsi, Korean, Italian, Turkish, Spanish, Swahili, and Vietnamese. And I think Dari has just been launched as well. So thank you everyone for your time. It's been a real pleasure to be speaking with you today. And of course, reach out if you want any more information about MCWH or the work that we do.
Thank you so much, Maria. It was a fantastic presentation and information about women and also the new resources. Really, I haven't gotten a chance to check those new resources, but it's really interesting to know that you have produced in a variety of languages. So maybe during this forum, I will be able to share it in the chat, the link to the resources. Thank you so much once again. So time for our first poll. All right, it's time for our next speakers. So let's welcome our two fabulous speakers from RhED, which is Resourcing Health and Education program. So our first speaker is Gabby Skelsey. Gabby is a health educator working in the RhED program. Gabby's work with the sex industry began in 1995 with the Prostitute Collective of Victoria, and then she transferred to the RhED program in 2000. Gabby provides confidential services to the sex industry across Victoria around health education, legislative information, support, and advocacy. This is delivered by outreach to brothels, escort agencies, and independent sex workers. Our next speaker is Petria Ness Irakola. Petria is a health educator holding the immigrant and multicultural portfolio with a background in social work and international relations. Petria has worked previously in the RhED's Pathway program as a case manager and has been with the RhED program overall since approximately 2016. In her role, Petria manages a team of community interpreters and translators that have both linguistic skills between English and languages other than English, and have nuanced understanding of the sex industry. As a health educator, Petria, alongside 3 other health educators, is responsible for providing information, education, support, referrals, and advocacy to sex workers across Victoria. Please welcome Gabby and Petria.
Thank you. While Petria, you get the slides up, I can start talking. Save us some time. So Petria and I are going to tag team this, and I'm just going to speak a little bit about the history, and then Petria, who holds the migrant portfolio, will talk about the current work that's going on. So just briefly, in 1995, when sex work became legal in Victoria under what they called the Prostitution Control Act, now called the Sex Act, and now it's beginning to be pulled down for decrim. But at the same time, I started working at PCV. And at that time, that's the Prostitutes Collective of Victoria. And at that time, there were about 45 brothels. Okay, then because it was legal, obviously many more brothels were opened, but also migrant workers started coming in, and they came from all around the world because Victoria was one of the few places that they knew they could work legally. And this has continued. So we have a lot of migrant workers from all over the world because sex workers like to travel. But for the purposes of what we're going to talk about today, I'm just going to talk about, and I think Petria will, about RhED migrant brothels. So back to 1995, there were 3 migrant brothels, and these workers were mainly from Thailand, a little bit from Cambodia and Vietnam and China, but mainly Thailand. And they would come in on contracts, and they would pay their contract off, and then they would stay. The contractor would organize the visas, the passports, the travel. So now let's fast forward to today. That was 1995. Brothels grew to over 100. And then what happened, it settled at about between 80 and 90. And over 60% of the industry became migrant brothels. So this changed the way the RhED program, PCV, and then the RhED program worked, in that we would deliver more resources in other languages, and we would try to employ bilingual peer workers. Ownership changed. So there was an influx of people, mainly from China, who became owners. And obviously the resources, all the health resources changed because they now had to be done in the predominant languages, which I remain today, which are Chinese, Korean, and Thai. Now, in a brothel, you'll see on that slide, in every brothel setting, there is signage at the front desk and in all the rooms about the Sex Work Act and sex slavery. I'm not saying it doesn't happen, but in my time, I have not had anyone come forward to me in my role at the RhED program. However, there's a lot of massage parlors, and we suspect that perhaps there is more of that going on there. We don't know though. So that'll be one of the wishes I have if DCRIM comes along and we get some more money. So all brothels have the sex slavery signage. All brothels have an example there is it is illegal to remove a condom in English and in Thai, Chinese, and Korean. And our RhED magazine, which if we were doing this in person, we would have a stack of RhED magazines we would give you. They have articles in English, Chinese, Korean, and Thai. So with that said, I'm going to hand over to Petrea, who will talk more about the current work and the impact of COVID-19. Thank you.
Thanks, Gabby. So I'm going to speak a bit more about COVID-19 and the impact that that's had on our work with sex workers and with migrant sex workers more specifically. So lockdowns have had a massive impact on the sex industry overall, and this has had a disproportionate impact on migrant sex workers. It's been common since the start of the pandemic for the sex industry to actually open up 1 to 2 weeks after restrictions have eased for most other businesses. And this has particularly been the case in relation to high volume venues such as strip clubs. This has meant that those working in the sex industry have often been the last to return to work once restrictions commence easing. Additionally, support for migrants on temporary visas has been piecemeal to non-existent. Scott Morrison had initially announced at the beginning of April that temporary visa holders such as working holiday makers and international students should quote unquote make their way back home if they found they were unable to support themselves financially. And later, some of the limited financial support that was made available were the ability to apply to the International Student Emergency Relief Fund, the Extreme Hardship Support Program delivered by the Red Cross, early access to a portion of their superannuation, and increased flexibility with visa requirements such as international students being permitted to work beyond the stipulated maximum of 40 hours per fortnight. Outside of the economic impacts of lockdowns, the communication of restrictions related to the sex industry has often been slow and confused, which has had an impact on all sex workers. And this has been concerning as most workers have wanted to ensure that they are working in compliance with COVID-19 restrictions, but the messaging has not always been timely nor clear. This has been particularly worrisome for some migrant sex workers, and especially sex workers whose first language is not English, as the new Australian immigration minister in December of 2020 threatened deportation to any temporary visa holder breaching COVID-19 restrictions. So the lack of financial support, coupled with poor communication of restrictions and easing of restrictions in the context of the sex industry, has meant that some sex workers have at times during the pandemic worked outside of the restrictions, either out of necessity or unintentionally. As such, some may have been reluctant to seek out sexual and reproductive health services due to fear of consequences of having worked outside of the restrictions. At RhED, we are aware that independent workers, including migrants, may have continued to provide services. And as our program is about harm reduction, we have supported these workers with resources to help them screen clients and for all sex workers to be able to work as safely as possible. And just leading on from that, some of the ways in which we've continued to support sex workers and migrant sex workers access needed services, including sexual and reproductive health services, have been engaging in outreach whenever possible. And that's been tricky during lockdowns, but we've managed to do it in certain situations to deliver safer sex items, starting out information and beyond. We've continued to deliver peer-only workshops, albeit digitally, reflecting community needs and interests during the pandemic. And we've ensured that our peer-only spaces continue to operate in some capacity. So we have two, one being RhED Rendezvous, which meets on the last Wednesday of every month. And we have another one, Hustling to Health, that's centered around street-based sex work. And that's continued to operate in different capacities throughout the pandemic. We've also been broadening and updating our referral list for sex worker allied services, including sex worker allied sexual health services. development of a series of fact sheets for COVID-19 related travel exemptions and restrictions for dual citizens, permanent residents, and temporary visa holders so that sex workers impacted would know their rights in the context of emergency travel. Liaising with Victorian police and creating a harmonization flyer for VicPol to actually hand out to people if they were going to, if they did suspect that somebody was in breach of those conditions. We had a bit of an arrangement where they would refer people to us and just give them this harmonization flyer instead of charging them. So that was something that was good. And that was translated into Thai, Korean, and simplified Chinese. And creation of a new sexual health and STI page on our website. Now, I just want to leave you with some final words on the impact of COVID-19 and changing demographics worth considering. So due to COVID-19, it is likely that the sex industry has experienced a change in demographics, and as a consequence, there may be changed needs and possibly changed barriers for migrant sex workers going forward. Many migrant sex workers on working holiday visas and some other temporary visa holders left early in the pandemic. And unfortunately, some migrant brothels have had to close permanently as a consequence of this exodus. However, other persons on temporary or permanent visas that have stayed here have commenced work in the sex industry for the first time to mitigate the economic impacts of pandemic lockdowns and meet their own unique financial needs. Further to this, still, some migrant workers have actually changed sectors in the industry, such as, and not just migrant sex workers, all sex workers, have changed sectors in the industry, such as from venue-based work to digital private work, in an effort to have the impacts of restrictions somewhat lessened. What this means is that when we do reach some semblance of operating within a COVID normal environment in Victoria, the sex industry will most likely look a little bit different than it currently does. And with changed demographics, again, come changed community needs, which we will have to pay careful attention to in order to guide our future work and projects. I totally got distracted and didn't even switch the slide. So there was my slide. But thank you guys. That was about all that we had for today.
Thank you so much, Petria. And I'm just sharing RhED's resource page on their website in the chat, and you can check all the resources, all the amazing resources they have on their page. And there's also a separate icon, as mentioned by Petria, for COVID-19. So thank you so much. Yay. All right, time for our second poll. So this is going to go on the poll thing. All right, so let's welcome our third speaker for the night, Michael Whelan. Michael is from Thorne Harbour, and he also leads PrEP Access Now, which is PAN in short. Michael works as a health promotion campaign lead in HIV prevention at Thorne Harbour Health, where he has led campaigns and projects supporting men who have sex with men. Michael also leads PAN, PrEP Access Now, which is a community-led not-for-profit organization advocating for and supporting equal access to HIV prevention medication, pre-exposure prophylaxis, or PrEP in short, particularly amongst people without Medicare. So let's welcome Michael.
Hello, hello. I'm just going to, hopefully you can hear me. I've just switched my audio input. I'm just going to share my screen. Just let me know, can you see that fine? Wonderful. Oh, I'm already getting ahead of myself. Hi, everyone. My name is Michael, as someone else said. Thank you so much for the introduction. I use he, him pronouns. I'm part of the health promotion team at Thorne Harbour Health. I'm also the chairperson, as Kenwell said, of PAN, so I'm going to be speaking kind of wearing both hats today. I would, of course, like to acknowledge the traditional owners of the lands on which we're meeting today. For me, that's the shared lands of the Boon Wurrung, Wurundjeri, Woiwurrung people of the larger Kulin Nation. And I would also like to extend that acknowledgement out to all of the countries, people in all of the countries we find ourselves on today, and acknowledge any Aboriginal and Torres Strait Islander people here today, and remind everyone that sovereignty was never ceded. Just for a little bit of quick background, Thorne Harbour Health is Australia's longest serving state-based HIV, AIDS and LGBTI health organisation in the country. We were established in 1983 and work across a diverse range of HIV and LGBTI health areas, obviously formed as part of the, during the AIDS crisis in the 80s, but we've expanded to a more diverse portfolio than that now, hence our name change from the Victorian AIDS Council to Thorne Harbour Health. We now operate in areas such as family violence, counselling, alcohol and other drug work, Indigenous and multicultural health, which forms part of the work that I do in our team. A little bit of HIV, STI, AIDS 101, just to kick us off. For those of you that work in the sector and deal with HIV, AIDS, hepatitis, BVVs, STIs every day, this is probably stuff that you'll know. HIV has formed the backbone of our work at Thorne Harbour for nearly 4 decades and is the focus of my role within the health promotion team. And I want to share a little bit of an overview about what HIV and HIV prevention kind of looks like in a 2021 context and beyond, obviously. HIV is a virus that attacks the body's immune system, which it weakens and makes fighting infection difficult. HIV can be present in blood, semen, breast milk, rectal fluid, vaginal fluid, and it can be transmitted through sharing injecting equipment such as needles, mother-to-child transmission through things like breastfeeding and pregnancy, and unprotected sex, which kind of forms the context in which I'm going to be talking about HIV today, which is during sexual intercourse. HIV is different than AIDS. Left untreated, a person living with HIV may go on to develop a number of opportunistic infections, which is what makes a person sick and can ultimately lead to death if left untreated. HIV is the virus and AIDS is what we call the group of infections that person may have. A person living with HIV does not necessarily have AIDS, but a person with AIDS defining illnesses is someone who is HIV positive. HIV and AIDS, different things. And that leads into the next very important part of my discussion today, which is undetectable viral load. When a person takes amazing medications to treat their HIV, antiretroviral medications, the amount of virus in their body is reduced to such a low level that the person cannot pass the virus on to another person. This is called having an undetectable viral load. UVL does not mean that HIV in that particular person is cured, nor is it a vaccine. However, there is a zero risk of transmitting HIV with a sustained undetectable viral load, and that makes it the single most effective tool that we have in preventing HIV transmission, which is very exciting. And that leads into what we call the U=U campaign. So some of you may have heard of undetectable viral load around online as undetectable, UVL, U=U, and U=U means undetectable equals untransmittable. So if someone has an undetectable viral load, they're on this effective HIV treatment, they cannot pass on the virus. There is a consensus among those of us working in the HIV field, researchers, people like myself working in health promotion, that U=U works. And here are just a couple of examples from across the globe, one of ours featuring the lovely Ryan, saying that he uses his undetectable viral load in his HIV prevention toolkit. Next on the chopping block is our good friend PEP, or post-exposure prophylaxis, is what we call the use of medication, the same exact medication, in fact, used by people living with HIV to treat their HIV in HIV-negative people to prevent HIV infection. If you're someone who's HIV negative and you come into contact with the virus, you can, of course, use PEP within 72 hours to help you stay HIV negative. PEP works for everyone, and you can get it from a GP, sexual health clinic, the emergency room. There's lots of different places. And a great place to try and find PEP is by going to this fantastic resource, getpep.info, which is, as I said, a fantastic resource, enables you to find PEP no matter where you are. There's a list of clinics across the country, phone number you can call to find a suitable clinic near you. And the important thing about PEP is that you need to take it within 72 hours of coming into the virus, into contact with the virus for it to be effective. And next is PrEP, which forms part of our HIV prevention toolkit and probably what I'm going to be spending the rest of the presentation talking about. PrEP, or pre-exposure prophylaxis, might be something that some people are familiar with. It certainly gets a little bit more attention than what PEP does. It was even highlighted on this season of Sex Education for anyone who is a fan. PEP and PrEP work very much the same. In fact, they use exactly the same kind of medication to do the amazing work that they do. The key here is pre and post. So where PEP is used after you've been exposed to HIV, you can use PrEP, pre-exposure prophylaxis, before HIV infection to stay protected from HIV. PrEP is almost 100% effective at preventing HIV. And unlike condoms, it takes your HIV prevention toolkit out of the bedroom, which is a really exciting thing for some people. So you can take care of your HIV prevention well ahead of time, so it won't break and it won't fall off. It won't get missed in the thrill of the moment. It sort of separates the sex act from your HIV prevention strategy, which is a really amazing tool. Condoms do obviously work to prevent HIV as well as STIs and unwanted pregnancy, and are a fantastic tool to keep on hand. However, if you aren't going to be using condoms all the time and you don't know the person's status of whom you might be hooking up with, PrEP is a wonderful tool to add to the toolkit to keep you HIV negative. Let's talk a little bit about PrEP. You can see a little bit of a transition in my slides as I take off my Thorne Harbour hat and maybe put my PAN or PrEP Access Now hat on. I want to talk a little bit about what taking PrEP kind of looks like. There are different ways of taking PrEP that work for different people. Sometimes that's taking PrEP daily. That's probably the one that people are the most familiar with, and it's certainly the most user-friendly. It's the one that all different kinds of bodies can take. So basically you take your PrEP pill once a day, every day, and you're protected from HIV round the clock 24/7, and it works for everyone. Really great, robust strategy. If you are a cisgender guy into other guys, you can take what's called on-demand PrEP. And that's a way of taking a few carefully timed pills that cover you for a brief period of time. So say you want protection for just to hook up over the weekend, as opposed to having to take PrEP every single day. Seasonal PrEP is another kind of new construct in the way that we think about taking PrEP. It's very similar to on-demand PrEP. It just means that the period of time you're taking it is a lot longer. Everyone can use seasonal PrEP. However, how you take it might vary depending on whether you're a cisgender guy into other guys, a cisgender woman, a trans woman, a trans man, a person that's transgender or gender diverse. There might be a slightly different startup and stopping routine depending on who you are. So important to talk to your doctor when you're thinking about a different PrEP strategy that might work for you. Here's a little bit of a quick emoji related PrEP on demand kind of schedule, what it kind of might look like. Oh, I'm just going to go back slightly. There we go. So the way that PrEP on demand works for anyone who is a cisgender guy into other guys, all you have to do is preload with 2 pills of PrEP before you have sex. You need to take it at least 2 hours before sex. And then you have all the sex that you like. That's the fun part within 24 hours. And then 24 hours after you've taken your double dose of PrEP, you take a single pill after that. And then 24 hours later, you take a 4th and final single PrEP pill. So 4 pills in total, and that covers you for this kind of brief interaction, as opposed to needing to take PrEP every single day for a month, 2 months, 3 months. So a really effective strategy if you're going to be going out partying. I know I certainly miss going out and partying. Everyone probably does. So that's a really effective strategy if you're out on the scene and just having casual sex every now and then. Here's a bit of a look into what the kind of PrEP cycle looks like. So if you're looking at starting PrEP, what you're going to be signing up for. So first thing that you need to do is go and see your doctor. And the good thing is that anyone can prescribe it. Anyone that's a doctor, of course. You can go to a specialist sexual health clinic, your family doctor, a sexual health service. You can go anywhere you like as long as there's a GP and they can prescribe PrEP. The doctor will ask you a few questions about your sex life, your sexual partners, your risk of acquiring HIV. And that can be a little bit, embarrassing for some people, but it's best to be as honest as possible because they can help you find the strategy that's going to work best for you, whether that's PrEP, using undetectable viral load, condoms, a mixture of the 3. After that, you'll get an HIV test, you'll be screened for STIs, and you don't need to be STI free in order to start taking PrEP. This is a question that we get quite a lot through PAN. So if a little bug pops up along the way in your sexual health testing, that's completely normal, that's fine. You can walk away with your PrEP and get treated for your STI at the same time. You don't need to wait for a clear STI test before you start taking PrEP, which is great. Your doctor will then provide you with a prescription for your PrEP drug, which is great. You then pop down to the pharmacy or buy it online. And then you've got your PrEP and you're protected from HIV for as long as you need to start taking it. Obviously, as I said before, the kind of strategy that you're taking will dictate how long you take it, how often you need to pop back to the doctor to refill your script. But then that cycle just starts all over again. So if you're taking daily PrEP, that's a really easy one to take because you just take it every single day. You just head back every 3 months and this cycle continues around and around and around. And you'll be continuing to test for STIs and things along the way as well because those will pop up. Big question we get asked is, what is the cost of PrEP? And that is a difficult question to answer sometimes, because depending on who you are, the price changes. PrEP is listed on the PDS, which means if you have Medicare, you can grab your PrEP from the pharmacy with your prescription, obviously, for just over $40 a month. Some pharmacies even offer it cheaper, and I've got some links to some of those pharmacies if you want a slightly better deal on your PrEP. If you don't have Medicare, if you just walk into the pharmacy with your script, it's about $180 to buy your PrEP, which is kind of, it's outside my budget, let's just say that. But there are other options. So you can purchase your PrEP through what we call personal importation. You can buy the same generic medications from overseas where it's produced a lot cheaper and get it imported into the country. Takes a little bit longer, but you end up paying about $20 a month, including the shipping, which is a pretty great deal. If for any reason you don't have access to Medicare or you can't afford PrEP for any other reason, you can access free PrEP coupons through PAN. These are available to anyone who needs them. So whether that's you don't have Medicare, you're an international student, you've lost work for COVID, any particular reason, you're just between work, you can apply for a free PrEP coupon, no questions asked, and we will get you your coupon, which is fun and exciting. Just go to the next slide. Finding PrEP, as I said, any doctor can prescribe PrEP, which is great, although not all doctors know about PrEP, or they might not have prescribed it before and they want to go away and do their research before they start prescribing it, which, you know, you want to make sure that you find a doctor that knows what they're talking about. So we at PAN have this fantastic little interactive map. It's just embedded in Google, and you can find a doctor that has at least put their hand up and said, hey, we're prescribing PrEP. We'd love for you to come to our clinic. We know what we're doing. Come to our clinic. We've also got on there a number of clinics that have, you know, if there's a specific doctor at that clinic and they only work every Tuesday, Thursday, which days to go and see that clinic, if that clinic's provided us that information, obviously. Going in a little bit closer to our kind of local area, as you can see, there's quite a lot of clinics. This isn't even exhaustive. This is just the ones that have told us that they're prescribing PrEP. There's tons across Victoria, across Melbourne, indeed the country. If you head to pan.org.au, you can find this list. And as I mentioned, we've got those clinics that mention which days they have a PrEP prescriber on board. I did want to highlight one particular clinic importantly, which is the PrEP.me clinic, which is run through Alfred Health out of the Alfred Hospital, which is connected obviously to Melbourne Sexual Health Centre. The PrEP.me clinic is a clinic that was specifically set up to support people that don't have Medicare. So if you don't have Medicare, you need access to PrEP, you can go to this clinic and both your doctor visit and all of the testing is done for free. Because we know from speaking to people without Medicare, a lot of the people that connect with us that are international students, they don't mind paying the import fee of $20 a month for PrEP. That's fine, they can afford that. But test all of the pathology testing that they need to routinely do every 3 months on top of paying for the doctor's visit can sometimes be the most onerous part financially for them. So this clinic will do all of the testing and the appointment for free, and they'll even connect you with us to do the to complete that cycle of applying for a PrEP coupon. So the entire cascade of care is done for free. A little bit of info about what our PrEP coupon scheme is. It's really simple. Once you've been to the doctor, whether that's at PrEP.me anywhere across the country, you just upload your prescription and some photo ID just so that we make sure that the script matches the person that it's going to go to. And you upload that to us, just say, hey, I don't have Medicare, or I'm a student, I've lost work, whatever it is, and we'll approve you for a PrEP coupon. It's really simple. We just give you a little coupon, you pop online and you enter that coupon in when you go to checkout, and it just nullifies all the cost, including the shipping. So it can take a little while for those to arrive because quite often they're being shipped from Eswatini or they're being shipped from India, and it can take a couple of weeks. So you've just got to factor that into your kind of ordering cycle, going back to your doctor to get a refill script a little bit earlier than you might anticipate. That's everything that I have on PrEP. I did mention a few resources there, so I've just brought those up onto the screen. Our work at Thorne Harbour Health, obviously, we've got a couple of sexual health resources there around undetectable viral load on PEP, those Get PEP website that I mentioned. And then there's just a couple of links to obviously PAN. There's a QR code. It is 2021. We love a QR code now. And a couple of other fantastic PrEP resources there as well. I look forward to answering any questions you might have either in the chat or in the Q&A. And even after this presentation, feel free to look us up. We'd love to help support you and your community.
Great. And we have got some amazing comments in the chat as well. Everybody loved the presentation.
Great.
Thank you so much, Michael. And we have got some questions in the chat already, which we will be asking you during our Q&A. So yeah, till then you can enjoy a cuppa. All right, poll time. Right. All right, let's invite our final speakers. So we have two great speakers for our final presentation. Emily Deng. Emily is a community engagement coordinator at 1800 My Options. She has worked with the service since its launch in 2018, providing lots of information and reassurance to Victorian women on topics like abortion and contraception. She has a particular research interest in reproductive justice and family violence in migrant and refugee communities. Our second speaker from 1800 My Options is Nabila Yusuf. Nabila is a multicultural engagement officer at 1800 My Options. She has nearly 10 years of combined experience in community development, public relations, strategic communications initiatives within the sexual health and environmental space. She has completed a master's in international community development and is currently pursuing a master's in public health, with research work focusing on migrant women's sexual and reproductive health. Let's welcome Nabila and Emily.
Hello, everyone. Thank you so much for joining us this afternoon. We hope you've been learning and enjoying it as much as we have. There's just, clearly so much amazing work being done in the space, and it's really, really lovely to see everyone here to support that. So today, Nabila and I will be talking to two main points. The first thing we wanted to talk about was how our service as part of the sexual and reproductive health system in Victoria has really seen some changes happening during the last 18 or so months as a result of COVID, and how that's really affected migrant and refugee women and international students' access to contraception and abortion care specifically. The second thing we wanted to talk to was some of the work that we've done as sort of a reflection of that, and some of the resources that we've made specifically for international students to support them in their help-seeking journey. So before we get started, I'd just like to pay my respects to the traditional custodians of the lands and the waters that we all meet on today. We'd like to pay our respects to them, their cultures, their elders, past, present, and emerging. We also recognise that sovereignty was never ceded, and that we're the beneficiaries of stolen land and dispossession, which began over 200 years ago and continues to this day. And I think that's just something that's important to reflect on, given that we are talking about, really entrenched health inequities. We're talking about cultural aspects around health, and those are all things that clearly affect all levels of Australian society. All right, so a little bit about who we are. 1800 My Options is primarily a phone line and an online service. We basically answer all of your questions around contraception, pregnancy options, particularly abortion, and sexual health. We're run through Women's Health Victoria, and we're funded by the Victorian government. So while we don't give specialised medical advice or counselling, we basically can give people lots of general evidence-based information around those topics, and we can also link them into services that will suit their needs. So this is a look at our Geo Mapping Service, so quite similar to what Michael was showing before with sort of PrEP prescribers, but this Geo Mapping basically lets you search for contraception services, abortion services, other sexual and reproductive health services, and you can also search by location. So for a lot of people, knowing where to go for a lot of those services can be really confusing. And we can also basically search for other criteria. So things like if there's multilingual services, multilingual practitioners at those services, if there's bulk billing available, or if there's private health insurance that's necessary. To date, we've supported over 15,000 Victorians, and we've got nearly 400 registered health services. Basically, who calls us? We've got a lot of women calling us, aged 26 to 35, followed by the 18 to 25 year age group. About a third of our callers have mentioned experiencing financial insecurity, and unsurprisingly, this number has increased to around 40% since the start of the year. Some of our callers have also presented with other concerns such as mental health issues or family violence. So that's definitely something that we're very sensitive to and aware of, that sexual and reproductive health isn't something that exists in a vacuum. It's linked to all other aspects of callers' lives. The majority of our callers are basically wanting health information and service referrals for abortion, contraception, and pregnancy options. So a really typical call might be something like, hi, I'm looking for somewhere to go for a medical termination. Do you know where I can go? Or I've just found out that I'm pregnant. I'm not sure who I should talk to. Do you know what I can do from this point? Or what are some of the available contraception options that I can access in Victoria?
And to add to that, among the individual barriers that some migrant women and international students might face is a lack of sex education, which links to a lower health literacy and facing financial hardship in terms of not having Medicare access, and also their private insurance access as well. And being located in a place where the services might not be around them or not being accessible via public transport, including their own religious and cultural values of seeing sex health as a taboo issue. That added on with other complexities such as health issues, disabilities, and as stated. And some of the systemic barriers that might also hinder them from accessing services could include the cost of services, because each service might have a different, they might basically charge differently from one to another, and the existence of health professionals who might be unaware of cultural sensitivities and might be obstructive, including the lack of rural or regional services, and as well as flexible service times, which as an international student, I completely understand. Having a part-time job and juggling that, and also the social stigma that is not only applicable to the migrant community or international students, but also among the society as a whole. To add to that, how 1-800-MY-OPTIONS currently help is that we can find new services that are financially suitable, meaning services that can directly bill with private insurance, such as overseas student health cover, services that can bulk bill you or give discounts for those that have healthcare card, and also free services that can be provided for asylum seekers and refugees. These two in finding services that are within your local area, as mentioned, and those that are culturally appropriate in the sense that they can maybe request for a female practitioner or one that can speak multiple languages. And in some cases, we might also be using an interpreter. And seeing how today's topic is mainly about how the pandemic has sort of affected us, definitely most of the migrant callers who have dialed in have reported feeling more stressed and isolated and having to experience reduced income. As we can see in the international student cohort, that they do experience this through the hospitality space, if that makes sense. And most of them are also hesitant to make non-urgent medical appointments just in the fear of the COVID spread and having to put other priorities like rent and food first beforehand.
Yeah. So COVID's not only impacted the way that our callers are feeling, it's also really impacted the way that health services now operate. So one of the really big shifts that we saw across the sexual reproductive health and all health services really was a big shift to telehealth appointments. The other thing that we noticed was that in some lockdowns, for some services, there were fewer available appointments or potentially just longer wait times for some specialists or some private clinics. So let's just sort of break down a little bit about what those changes have meant for service users. So with telehealth, one of the first things that we've noticed is that telehealth can really offer some great flexibility and convenience. You can be really comfortable at home in your track pants instead of waiting in a waiting room for 3 hours. It's also meant a lot more access for some patients, particularly rural and regional patients who maybe in the past had to travel quite a long distance just to pick up a contraception script. However, telehealth has also had some issues associated with it. So people who are using telehealth might not have complete privacy from other people in the house. And that can be really difficult if callers are experiencing family violence. So it's harder for practitioners to actually screen for family violence. The other thing it means when you're not doing face-to-face appointments with people is that doctors can't really do incidental STI or cervical screening. So just to sort of bring back to what Carnwell was saying, that CH was doing a campaign to catch up on STI testing and to catch up on cervical screening. So that's something that we're hoping really gets across in the next few months. So I guess basically the takeaway for telehealth services is that we would like telehealth services to continue. They're unfortunately scheduled to end for sexual and reproductive health services this year. However, we think that the flexibility and the convenience and the choice that it's offered patients really needs to continue into the future. The second thing that we've sort of noticed during COVID has been some impacts on surgical abortion access in Victoria. So as a caveat, I will make clear that the majority of abortion seekers are contacting us and are getting abortions before 9 weeks. So that's still when they have the option of either having a medication abortion or a surgical abortion. But for the callers who are contacting us potentially later into the pregnancy, up to 24 weeks, which is the legal limit in Victoria, services do become a lot more limited. And this isn't necessarily a COVID specific thing. Before COVID, there was actually only one private service that went all the way up to 24 weeks gestation. But since the months following COVID, we currently actually have no private clinics that go all the way to 24 weeks. So at the moment, there's only one public hospital in all of Victoria that can go to 24 weeks. Being the only service, obviously it faces quite high demand, and there's, as a public hospital, also a lot of challenges for people who don't have Medicare cards or people who are wanting abortions from interstate. So those, I guess, are the main issues that we've noticed with the service system as a result of the last few months. The other work that we wanted to talk about today was some of our international student work. And to speak more to that, Nabila.
Thanks. Yeah, the international student project basically was meant to educate and empower our international student cohort here and in Australia, basically. But thus far, 1-800-MY-OPTIONS as a service have noticed that about 5 to 10% of our calls are from international students, and that a majority of them are based in Melbourne, local government areas, followed by the northwest suburbs. And that more than 90% of international students are basically between the age of 18 to 35 years old. And also, adding to what Maria mentioned earlier, we needed a little bit of data in that sense. Majority of our overseas born callers are from Southern and Central Asia, Southeast Asia, and as stated. So with the project, what we did was basically run an online survey exploring international students' self-reported assessment of basically their knowledge and ability to help seek and how COVID-19 has impacted that. And also we ran a couple of focus groups to deepen our findings and provide some feedback on our existing resources, including a lot of engagement work with students around with private accommodation facilities, student union groups, OSHC providers like Medibank and whatnot, community organizations and educational institutions like Monash and Swinburne and a couple more. And this is one of the quotes that basically reflects one of what the focus group participants mentioned. They said that they don't know much about contraception besides the emergency pill, but it would be helpful for them to actually see live experiences of how different women respond to other types of contraceptions. All good. And it's okay. And all of some of the findings that we did have was basically a general lack of knowledge and confidence among international students on where they can go to find sexual and reproductive health services, especially around issues of permanent contraception and abortion. And most of them had a lot of preference to seek information about these issues through mixed sources, such as online search, so your typical Google, their peers, their friends, and doctors. And they also see them as their most trusted source of information. And unfortunately for us, phone services were clearly not preferred by those surveyed, basically just because of feeling embarrassed to come forward and be on the phones with someone. And moving forward with the project and all of the engagement work that we've done, what we have found is basically that health services should be able to provide online booking facilities, and also in a way help by clearly listing SRH services that are offered by individual GPs, information more about compatibility about insurance, health insurance, and as Emily advocated earlier, basically to extend the telehealth options for SRH, because that choice is very much important. And also just increasing the availability and awareness of long-acting reversible contraception, such as IUDs, and medical abortion in primary care settings. And from a health information services perspective, maybe to build more online presence and ensure mobile optimization, maybe more updated international student-specific information, and having resources that are available for people who need them in other community languages. And these are some of the resources that we came up with, some fact sheets, mainly around areas of roles of different health professionals in Australia, the things that you can ask as an international student with your GP, and around issues of medical privacy, and among those. And also, we've also come up with some animation videos just to demonstrate how it is when you do call us around issues of pregnancy options, contraception, etc. And we did also manage to collaborate with Milk Magazine on just basically developing videos around myth busting sexual and reproductive health issues, and also some articles that is basically demonstrating how it is when an international student uses 1-800.
Fantastic. We've also got some other general resources that we've developed. So we've got our general promotional brochures in a variety of community languages that we've noticed we're getting a lot of callers from that are requesting interpreters, or that are mentioning that's sort of the community group they're coming from. We've also got some fact sheets and zines, which are targeted at sort of a younger community audience, as well as short videos, which are hopefully as informative as they are engaging and interesting to share around. So if you would like any of these resources, if you know of any health services or community groups, whatever it is that might benefit from having these, please give us a shout out. We can send a big pack your way. All right, that's pretty much us for today. If you've got any questions, please feel free to ask later on. But otherwise, thank you so much for being here, listening to us, and hopefully you've all taken out something from the session.
Thank you.
Thank you, Emily and Nabila. That was quite informative. And I have actually shared all the resources which Emily mentioned in the chat box. And we actually finished our presentations on time. Yay! So now we are opening the forum for Q&A. So you can actually unmute your mic and ask the question yourself, or you can post the question in the chat box and I'll ask them for you, and then our speakers will answer. So our first question is from Michael. So this question has two parts. First part is, can pregnant women take PrEP? And the second part is, can women on PrEP have children?
The answer to both is yes. Just as it is perfectly safe and effective for pregnant women and women hoping to conceive to use antiretroviral therapy, because it's the same, they are the same class of drug. They're in fact many times the exact same drug. Yes, but very, very safe. Obviously, chat about any concerns you have directly with your healthcare physician. But yeah, very, very safe and recommended to do so.
Great. Our next question is from Emily and Nabila. So students, especially international students, they on OSHC, they have to wait for 1 year to access termination services. What if an international student has to access termination services before that 1 year ends, and how things have changed during COVID?
I'm happy to take this one, Nabila, if you wanted to. Yeah. Yeah, so
I'll add in.
yeah, it's basically a really common scenario that we have. A lot of international students, actually everyone, not necessarily everyone reads through the fine print of their private insurance policy when they're taking it out. So a lot of students might not notice that there is basically a 12-month waiting period before they can access pregnancy-related care. Abortion in some instances does fall under that. Basically, it is still possible to access services. The only issue is that the cost might vary quite dramatically. So the reason the cost can vary so dramatically is because it depends on the type of abortion that you're having. So we mentioned before, there's medication abortion options and there's surgical abortion options. With the medication abortion options, there's actually some GPs that can directly bill that just as an extended consultation. So if basically you catch the pregnancy quite early on and it's before 9 weeks and you decide you want to have a medication abortion, it can actually be quite affordable in that you can go to a GP that does prescribe medication abortion and they can direct bill with your insurance provider just as a general consult. Unfortunately, if you're looking into surgical options, you will be paying a lot more out of pocket, but it doesn't mean that you can't access it. It just means that the service, unfortunately, will be a lot more expensive. So the cost basically increases the more weeks pregnant that you are. So in general, raising awareness around unplanned pregnancy, raising awareness around the most effective contraception options, such as LARC options. So things like the implant, the IUDs, those are sort of the best ways that we can avoid international students being in that situation where they're really struggling to be able to pay for services, such as an abortion after that medication period has ended.
Thank you so much. Our next question is from Maria. So thanks for sharing the findings of the data report, Maria. Could you please share the learnings of the evaluation and what were the limitations of that evaluation?
Thanks for the question, Natalia. I'm just wondering if you're talking about the evaluation of the data that we've sourced or the evaluation of our own program or report?
Could be both, if you can.
Yeah, so in terms of evaluating programs for migrant and refugee women's sexual and reproductive health, is that what you're referring to? So whether or not certain programs like the health education program have been successful and I'm just trying to get a sense of what you mean by evaluation, because we didn't actually, in our data report, we didn't actually evaluate the programs or the projects that were described in the papers. A, because often it wasn't documented, and B, evaluation differs across various programs and projects. And so the criteria for success change depending on the organisation and what they were actually evaluating themselves. So we can say that in certain parts of Australia, for example, in New South Wales, there was one program in maternal and child health that engaged bilingual health educators as kind of peer educators to work with migrant and refugee women in sort of helping them overcome some of the barriers that they were facing. There was only a very limited sort of explanation around evaluation because the project was quite short, but they found that that having bilingual and bicultural workers working within the service really did increase access to services, basically, and that women found the experience of accessing that service much more effective, and they felt much more culturally safe being able to be guided by bicultural, bilingual health educators. But apart from that one program in New South Wales, and I can share that research with you, Natalia, there was not a whole lot of evaluation. And like I said, it's quite difficult because the evaluation frameworks are so different across the projects and the programs. It's difficult to kind of, to say that this worked. So I guess part of that is really we need to build on the evidence that we have, and do more research into what works and what's culturally responsive.
Thank you.
Thanks for that, Maria.
Thank you, Maria. And I actually forgot to post the poll after 1800 by options presentation. I'm really sorry. So can I please request you all to answer it now? This happens. I'm really sorry. Oh, wow. All right. Thank you so much. Our next question is from Petria and Gabby. So what advice would you give, or how does RhED support the new sex workers? For example, if someone is new in the country or new to the industry, how can they access the assistance from RhED? Is there a pathway where they can, is there a number, or is there a link where they can contact you?
Yeah, so we have it, they can find us on our website. So sex worker at sexworker.org, or sorry, sexworker.org.au, or they can ring. We have a phone number as well that we don't have, unfortunately, with lockdowns right now, we're not all on site at any given time, but yeah, we're contactable by phone. You can contact us on social media as well. And we do have peer health educators that can speak to people if they want to speak with a peer. We can arrange that as well.
And I think we also have the starting out kit on our website.
Absolutely.
And available in other languages. So that's useful it's even useful for workers who are, who've been working a couple of years, because it's got very valuable information from everything around how to manage your sexual health and STIs, and also, about boundaries, who to tell, how to get support.
Well, someone has just commented they love your starting out kits. It's really great. All right, so our next question is around confidentiality, and it's from Michael and Emily both. So if you both can just tell the audience a little bit about how the confidentiality and privacy of people who are calling to access these services, for example, PrEP and termination services, how is the privacy and confidentiality maintained throughout?
I can jump in and speak from a PrEP perspective if you like first. So we operate PAN as a Facebook group and as a website. So a lot of people come through to us in a semi-de-identified fashion, in that they're in a Facebook group and not a public page. But most people are there to connect with peers, and so they will often share their experiences around, what was my, I experienced a side effect. Did anyone else? My GP doesn't prescribe. Where did you go? So there's a lot of community connection that happens in a somewhat public fashion. In terms of people accessing coupons, the information that comes through is submitted just through a Google form, and that only comes through to our small committee, so there's only 5 of us, and then that data is then, once we've processed it, we delete the information that people provide, like their prescriptions, and just de-identify everything, and that just stays within our team. It doesn't get shared with researchers or anything like that.
I guess from our perspective, there's a few different sort of levels to confidentiality. So first of all, if someone's contacting our phone service, it's a completely confidential and anonymous service. You can give us a fake name, we don't care. You can say you're calling for a friend, it doesn't matter. Basically, we'll just work with you to make sure that we're getting you a few different service options that can actually help you. So if someone calls up and says, my friend needs an abortion, what can we do? We can sort of just walk through that with them. And then at the end of the call, we don't have any identifying information on them. So it is completely anonymous. If they call back, there's no way for us to know which person they talk to over the phones. So they might get someone completely different. So basically every single time you call, it is a completely anonymous and confidential service that we offer. In terms of other concerns around confidentiality when accessing abortion, a lot of people, or even accessing STI testing or contraception, a lot of particularly younger people or international students might be really worried around privacy and around confidentiality. They might be worried that potentially their parents or their partners or their universities or their employers might actually be able to find out that they've had a termination or that they've tested positive to chlamydia or whatever it is. So a lot of what we do is actually just reassure people that in Australia, there's very strict privacy laws around your medical information, and that basically you're the only person who can access that. We also encourage young people that basically they can get their own Medicare card from the age of 15. And not a lot of people know, but basically from the age of 14, you have your own Medicare account. So that basically means that no one else can look at your medical records or where you've been with your Medicare without your consent. So those are some of the things that we do to really reassure people and make sure that they've got some confidence that the health system will really protect them and their privacy. The final thing is that, I guess, around accessing services, it can be really difficult to maintain privacy if you're in a super rural or regional area, or if you're coming from certain communities and you want to talk to someone else within the same community. So we've had, some rural callers who might say, I'm not comfortable going to the only clinic in town that provides medical termination because my aunt is the receptionist. Or we've had some people who are potentially calling from Aboriginal backgrounds who don't want to use an Aboriginal health service because they're worried about that sort of run-in with small communities. So we can definitely sort of work around those things and figure out what are some of the other services that you can go to avoid some of those privacy or confidentiality concerns.
Thank you, Emily and Michael. That was quite comprehensive. I have another question. So this question is from all of you. What things you wished medical professionals knew to help better provide services to your respective communities or clientele you look after?
I can go first, Carmel.
Yeah.
I guess from the Multicultural Centre for Women's Health perspective and the training, the culturally sort of responsive training that we run with community workers and health professionals, is that we have to move beyond this discourse of cultural competency and understand that, in order for us to work in culturally safe ways, we have to understand as professionals, our own cultural practice. We have to understand that we are embedded in cultural systems ourselves, and those systems are imbued with power, and that, we have to look at our own cultures before we can, work with people from other cultures. I mean, it's a process of self-reflection and looking inwards as much as it is thinking about, what this person, the context of this person's life and how to work effectively with cultural communities. So I think it's really about reframing our understanding of culture, thinking about it in much more complex ways, and thinking about cultures in terms of systems and politics and power.
Thank you so much, Maria. Yeah, Gabby.
Oh.
You unmute your mic, so I was like, maybe you were going next.
Do you want me to go next?
Yeah.
Well, it's just, I always say this is a very simple thing. I think that medical places, doctors, surgeries, and so forth, should have signage that welcomes sex workers, similar to signage that has gone into many places around the medical fraternity about welcoming gender diverse people, HIV positive people, and similar. And I know this is a challenge because Patria will be able to address this too. We do we do a lot of secondary consultations to people who may encounter sex workers in their work. And what we are currently doing is rolling out presentations to medical doctors who are doing STI testing for sex workers. And for them to get their head around why they're doing it, how they're doing it, is just like the tip of the iceberg. They have very little understanding of the greatest mental health problems for sex workers is the stigma and discrimination they face. And that is when they go and see doctors, who often will ask, the first thing they'll ask is, you do use condoms, don't you? Which is just so wrong. So anyway, that's what I would like, sex worker friendly signage in medical places.
Totally. Thank you. Michael?
Yes, thanks, Martin.
I guess mine's a little bit general in terms of you know, how we as a broader community and also within the healthcare space think about HIV and what a person living with HIV looks like. And what I would like to see is a more broader understanding of that HIV really does affect everyone, and it does not discriminate. That we've heard stories of, you know, particularly women presenting, you know, with, you know, AIDS defining illnesses, and just the doctor just isn't clicking that this person could have acquired HIV because they don't look like what they think a person living with HIV looks like, which, you know, it ties back to, you know, HIV stigma and discrimination. So I would like a more holistic understanding of what routine care for HIV testing, I guess, looks like, and understanding that HIV affects everyone, and therefore the tools that we need to prevent HIV can therefore be for everyone. PrEP isn't just for gay men, it's for anyone that, you know, that wants to prevent HIV.
Okay, lucky last. Anyone from Emily or Nabila? And then I'll ask our last question. I promise.
I guess, I think what I would actually want to ask back to everyone is actually just around what we wish medical professionals knew to better provide services. So there was stuff around like, don't ask a sex worker if they use a condom, and making services more visible. If there's any other things that we could encourage medical professionals to put into practice. I guess from our perspective, we'd really like it if they could do some medical termination training, and be aware around like how much a difference direct billing can make for a lot of migrants, particularly international students. Yeah. If anyone else has got any suggestions for us.
I think I have. Oh, sorry, Michael, you can go first.
Oh, something that I always talk to medical practitioners about, something that requires effectively no skill, no onboarding, no all-day training sessions, is just look at your intake forms. Have a look at how the language on your intake forms when you're bringing in a new patient looks like. If it says, what is your gender, male, female, like this person's obviously already going to have a negative experience with your service. And it's often the first thing that someone engages with when they've booked the appointment. They then get presented that clipboard and they go to fill it out and they go, I'm already not welcome here. So something really easy is to look at how inclusive your intake forms are.
Yeah, thank you so much. And I think what I was going to say was the exact same thing, language. How inclusive your language is. And obviously you don't need a lot of training or days or hours of training. You just have to be a bit more inclusive in your language, because that's the first impression your patient get. So anyway, thank you so much. And lucky last question. I would like to request all our speakers to share 2 of their most favorite resources with our audience, which have helped you in your work. So these resources can be anything, resources from your organization or books, podcasts, or TV series like sex education. So it can be anything, your 2 most favorite resources.
I'm happy to go first on this one.
Yeah.
There's a website and a group that I really enjoy looking at their work, which is Decolonizing Contraception. So they bring a really interesting perspective around reproductive justice as a shift away from just reproductive rights, and looking at to some of the, I guess, racial and like not necessarily equitable histories around contraception and contraception access as it is today. So I think that's a really useful site for anyone who might be interested in the sexual and reproductive health space that wants to look at a more intersectional lens on some of those histories. The other thing I would really recommend is the book Choice Words. I'm a bit of a history nerd, and I think it's just so interesting to learn about the history of abortion access in Victoria, and just to sort of understand that we are continuing some of the work that's been in place for a really long time, and that there's still, unfortunately, a lot more work to do. So those are my 2 picks.
Yeah, Maria?
Yes, Emily, just following on from you. I guess it's an intersectional feminist approach that informs MCWH. And so understanding where that comes from, what drives the movement, it's a political movement that was, first brought out of Black feminism in the US, and to really kind of understand that it's a political movement that that places the individual within systems and structures. And so I don't have 2 resources, Carmwell, but it would be really just to get your hands on everything that you can read about intersectionality, and also looking at Aboriginal writers such as Eileen Morton Robinson talking up to the white woman, Bell Hooks, Audre Lorde, Patricia Hill Collins. It's so important to familiarise ourselves with these scholars who center their own lived experience and shape our understanding of what it's like to be an individual, a person of colour existing within, quite racist structures sometimes. So that's just kind of my read as much as you can and do as much homework as you can. Yeah.
Patria?
Yeah, so I'll just share, I think one of the things that has been really useful in the course of my work at RhED, and I know for Gabby as well, is we've got the Little Red Book, which was produced by Scarlet Alliance, which is the national peer sex worker organization in Australia. And they're actually fantastic. I'll try and show you a little bit, but it's all on STIs and sexual health. And they've got like little pictures and descriptions. It's translated into Korean, Thai, and simplified Chinese again. So it's just a really handy resource for sex workers and for those serving sex workers. So that was one of my picks. And then in terms of a couple of books that I really like for my work and my role specifically, is one by Julie Ham. So Sex Work, Immigration and Social Difference, and also Sex at the Margins. And that's by Laura Agustin. And they're both really fantastic at really looking at at sex work, but looking at migrant sex work, not as the kind of stereotypical kind of destitute migrant sex worker kind of image, but it looks at kind of the diversity of migrant sex workers and what that experience looks like. So they're both really fantastic books, but Scarlet Alliance's publication on STIs was a hit for many years at RhED.
Thank you. Gabby, would you like to add something?
Oh, well, I echo Patria with the Little Red Book. And the other thing that came to mind was there were 2 TV series. One was called Satisfaction, which I thought was a very good overview of how the sex industry works in Melbourne. And the other one is a film called The Sessions, which looks at sex work and working with people with disability. So those 2 that just came to mind very quickly.
Wow. Thank you. Nabila?
I think one of the ones that really helped me is the TV series, the You Can't Ask That, the one that sort of works around myth busting, and also, well, I think you stole my answer, Kanwal, sex education. That's sort of current, and it sort of made it feel really relatable. And coming from back home in Malaysia, Like it's not something that you can talk about. So seeing that in the media and on a TV and tackling different issues is definitely helpful. And definitely cliche is the 1-800 website. That definitely helped me when I first started the job and to this very day with all my research work and whatnot.
Thank you. And Michael.
I've got too many I've just been thinking of more and more and more as you've all been speaking. I wish I went first. I've got tons that I love. One, I was mentioning on-demand prep earlier. And there's this little gang of folk that put together this cute little animated video around how to take on-demand prep. And it's really sweet. It's really, the language is really soft. It's really accessible. And I just really love watching it. It's called Rinse and Repeat is the website, which I've just shared a link to in the chat. It's a gorgeous little animation. Samuel Leighton Dorr animated that, who is an Australian queer illustrator and animator. And I have to give a shout out to my colleague who also runs a separate prep advocacy group. The lovely Chris Williams heads up Prep for Change, and they often do a monthly prep price watch. So as the dollar shifts or as prep price changes overseas, they do a regular prep price update on their Facebook group, and they've also got a website just like Pan does. And also one that I refer to all the time, and we're very lucky to be partnering with at Thorne Harbour to kind of co-produce, is the folk at MHARS have some really great prep information in languages other than English, which I refer to all the time. And in fact, if you go to the PAN website, there's little flags down the bottom and it links to prep information in all those different languages. These are more resources that I just love having at my fingertips to share with people in the community, more so than what changes the way that I work, I guess.
Thank you so much. And in the end, I just want to say that although our Sextember forum is over, but it's really important to keep these discussion and conversation going, and do share all the resources and all the information you have learned today with your friends. And last poll. Oh no, I've already done that. Thank you. Thanks everyone for joining us. It was really great to hear from a diverse range of speakers and on diverse range of topics. So thanks again to all our speakers, and I would try my best to email everyone with the post-session notes and the recording after this. But please give me a couple of days. Thank you and have a great evening. Bye-bye.
Bye.
Thank you.
Thank you.
Thanks, Kanwal.
Thank you. Bye-bye.